So, today we will discuss about the cholangiocarcinoma. Incidence is 1.1 to 1.5 lakh. 3% GI malignancy is responsible for this. The usual age of presentation is 65 years and sex is male female ratio 1.5:1. The common site is 60% in the hilar cholangiocarcinoma and 20 to 30% in the distal CVT, and intrahepatic 10 to 20 to 30%. If we consider the risk factor, we can say it with the 6C. 6C are cholangitis, colitis, clonorrheisis, colorectal cyst, and Caroli's disease. There are also chemical carcinogens. Here we can see this is a picture of cholangitis and this is the colitis. We can see this and memorize this. And this is a picture of the clonorrheisis and we can see the colorectal cyst. So these are the picture we can keep this in our mind, and this is a Caroli's disease. Okay, now we will know what are the risk factor of the cholangiocarcinoma. The cholangiocarcinoma, there is a chronic inflammatory condition. These are the primary sclerosing cholangitis, more than 20-fold increase in cholangiocarcinoma. There is increased chance in the hepatic cholelithiasis, or stone in the intrahepatic biliary channel, and there are also oriental cholangiohepatitis, and there is also oriental cholangiohepatitis. Here we can hepatitis. There is also chance of hepatitis C infection, and there are also parasitic infection such as Opisthochis viverrini, Clonorrheisis sinensis, biliary ascariasis, and hepatic schistosomiasis. So here I have already told that Opisthochis viverrini, Clonorrheisis sinensis, biliary ascariasis, and hepatic schistosomiasis. There are some congenital anomalies. Those are colorectal cyst and Caroli's disease. 6 to 30% mean age of development is 32 years. That is usually in the colorectal cyst. We have to go for, and there is also chance of Caroli's disease. And there are some chemical agents responsible for this risk factor. Those are thorium dioxide and vinyl fluoride. And also there is digoxin, asbestos, and nitrosamine. Post surgical, there is biliary enteric anastomosis. There is increased chance of malignancy, and some genetic disorders such as Lynch syndrome and biliary papillomatosis. If we now discuss about the histology, there is a spreads of longitudinal subepithelial way, and there is perineural and lymphovascular invasion usually seen. There are 3 histological types, and those are sclerosing, nodular, and papillary. Usually we can see the annular thickening in the bile duct in here in the sclerosing type. So there I am discussing about the subtypes. 3 subtypes. One is sclerosing, one is nodular, and one is papillary. The sclerosing subtype are most common and extends in the subepithelial manner. So here we can see the subepithelial manner extension, and also there is without obstruction of the component and annular thickening, and nodular projects in the lumen, and there is also annular thickening of the duct, and papillary, it is up to 10% of the cholangiocarcinoma are most common in the distal bile duct and less risk of invasive component, more easily resectable, and have better prognosis. It is as it is distal, it is easily resectable. And there are some morphological type also. Those are mass forming, periductal, infiltrating, and intraductal. Now we can see the periductal infiltrating, and this is intraductal. If you consider a mass form, so we can understand mass forming, periductal infiltrating, and intraductal. So if we want to know about the mass forming, this is a tumor from the nodule, which usually 1 to 2 centimeter in diameter, nodular, and tumors obstruct the bile duct, and there is penetration of the wall and periductal invasion and luminal surface narrowing, usually irregular. Luminal surface irregular, and ultrasound CT scan, MRI, MR cholangiography easily detect the tumor mass plus proximal dilatation. So here we can see by the picture there is proximal dilatation, and this is the mass. Now we have there the prognosis is very good. Now we have to know about the periductal infiltrating type. The tumor appears diffuse, firm, grayish white, annular thickening in the extrahepatic duct, and on the thickness of the wall is up to 1 centimeter. On CT or MRI, thickened duct can be visualized and enhancing ring or spot prognosis. Thickness is already I have mentioned, it is 1 centimeter. On CT and MRI, there is thickened bile duct can be visualized and as enhancing ring spot. And here the prognosis is worse. I have to keep it on mind. Here the prognosis is worse as it's involved in the nerve perineural protohepatis. Now we will discuss about the intraductal growing type. So here the polypoid sessile or the polyp-like mass is spreading along the lumen. In the lumen, the discrete multiple tumor cholangiocarcinomatosis, and it is spreading superficially, and it is friable, slough easily when it touched and rubbed in the time of surgery. It can also slough spontaneous bile duct stone and occlude the bile duct. CT MRI, it presents as a sessile or cast-like mass, and here the prognosis is good. In early stage good, but if tumor emboli, it is bad. Now we will discuss about the classification of the cholangiocarcinoma or Bismuth classification. By the picture we will see the different type of cholangiocarcinoma. This is that I am now drawing the picture. Type 1, type 2, type 3, type 4. Type 1, below the confluence of the right and left hepatic duct. Type 2, reaching the confluence of the right and left hepatic duct. Type 3, involving the common hepatic duct and right left hepatic or left hepatic duct. And type 4, involving both the right, left and common hepatic duct and the confluence, as well as there may be multicentric. Here we are drawing now type 4, where it is involving the right hepatic duct, left hepatic duct and the confluence. Now we consider clinical features. There is symptom: non-specific abdominal pain, early satiety, anorexia, weight loss, jaundice, steatorrhea, darkening of urine, pruritus. The sign: jaundice, cachexia, and palpable gallbladder. It is in the obstruction of distal CBD. So this is the Courvoisier sign. The investigation is liver function test. Here the bilirubin alkaline phosphatase, gamma glutamyl transferase will be raised. Tumor marker, we have to perform CA99 and ultrasound, MDT, MDRCT actually, to detect that intrahepatic biliary radical dilatation, tumor itself, and hilar lymph node hepatic mets deposit could be identified. So I already mentioned MRI, MRCP direct. We can also perform direct cholangiography using ERCP, and we can also perform PTC, Parkinson's prefer more for proximal lesion, percutaneous, and we can also go for PET CT scan and diagnostic laparoscopy. Here we can see the picture of the diagnostic laparoscopy. So if we want to say about the staging of the cholangiocarcinoma, it is divided into TNM, T for TX, T0, T1 T0, TX for no primary tumor, T0 no evidence of the primary tumor, TISL carcinoma C2, and T1 confined into the bile duct. And if you consider T2A is adjacent liver parenchyma. T2B, tumor invades in the unilateral branches of either portal vein or hepatic artery. T3, tumor invades in the main portal vein or bilateral portal vein or common hepatic artery, or the second order biliary radicals bilaterally, or unilateral second order biliary radicals with contralateral portal vein hepatic artery. There is a various type. Now we are drawing the picture here. This is a hepatic artery. It is a T1A. T1, when the tumor invades, tumor confined within the invades beyond the wall of the bile duct and surrounding adipose tissue. T2, tumor invades beyond the wall of the bile duct to surrounding adipose tissue, and when tumor is confined in the bile duct, it is called the T1. T2B invades the adjacent hepatic parenchyma, and T3, T2B is unilateral branches of portal vein and hepatic artery. T3, main portal vein. Or branches of the bilateral, the common hepatic artery, or the second order biliary radicals bilaterally, or unilateral second order biliary radicals with contralateral portal vein and hepatic artery involvement. This is a big part. So T2A, adipose tissue, T2B, liver parenchyma, T3, unilateral hepatic artery portal vein, T4, MPV or bilateral portal vein or hepatic artery, or second order biliary radicals bilaterally, or second order biliary radicals unilateral with contralateral portal vein hepatic artery. NX or no lymph node, N0 no regional lymph node, N1 if the lymph node is involved in the cystic duct, common bile duct and hepatic artery portal vein. N2 if there is a periaortic and pericarpal involvement, M0 is M0, M1 holo MERS. If we come to the stage is divided into 0, 1, 2, 3A, 3B, 4A, 4B. 0 is 0, 1 is T1, 2 is T2A and 2B, 3A is T3, 4B is at first N1, or T1, 2, 3 animal could occur. T4A, N0, N1 and T4, and 4B any T, N2 or nil, अथवा M1 any T any N. So this is the staging. Now treatment treatment depends on multidisciplinary team approach and site of disease. So our aim is to margin clearance, biliary enteric drainage. If it is in the distal third, Whipple procedure, in the middle third excision of the tumor and Rowan-Y hepatic angiostomy. And main discussion is about the intrahepatic biliary channel of distal proximal cholangiocarcinoma or hilar cholangiocarcinoma 60 to 70%. Our plan is R0 resection along with partial hepatectomy with or without chordate lobectomy. Simple excision of the extrahepatic bile duct along without hepatic resection is across the high risk of margin positive resection. So, simple excision without hepatectomy, there is a chance of margin positive. So, right extended hepatectomy is maybe done if the tumor is present in the or apparent in the right axis. So resection of the chordate lobe is recommended in almost all the cases in the centrally locating tumor because there are almost always biliary branches draining into the chordate, and there is all empirical portal vein resection increase the survivability than margin negative resection without portal vein resection. So here empirical portal vein resection increase the survivability than margin negative resection without portal vein resection. Now in case of frozen section at the level of the final proximal margin, placement of the retrograde transhepatic biliary stents across the jejunal anastomosis is palliative if there is needed of the palliative photodynamic therapy or other intrabiliary treatment are planned. If tumor is found to be unresectable after diffusion mobilization of the CBD, Rowan-Y hepatic angiostomy is performed to establish biliary enteric continuity with retrograde transhepatic biliary stents. So we need to establish biliary retrohepatic transhepatic stents, and we can also go for what? We can also go for liver transplant. So we have to keep this in our mind. So there is some indication if the patient is tumor locally advanced, unresectable, and we have to give prerequisite is neoadjuvant chemo radiation, and prognosis is good 76%. Treatment depends on the location, vascular involvement, and atrophy or lobar atrophy of the liver lobe. (10 to 15% suitable for surgical resection without offers only hope for long-term survival, and perioperative mortality is less than 5% at present. So prognosis is median survival rate is 18 months. Adjuvant chemo radiotherapy have to be provided, but it has no little role or limited role. Recurrence rate is very high. We have to keep this in our mind. And if there is biliary obstruction, we can overcome it by ERCP or PTC.